Hi, everyone, and welcome to the Claims Theory podcast, where we explore the latest innovations and challenges in healthcare revenue cycle. I'm your host, Lindsay Gross, and today we have the pleasure of speaking with Mark Dorner, a healthcare technology leader with over 30 years of experience. He was the chief architect at Relay Health and has built and led multiple global healthcare companies and is now the CEO of PreciseMDX, where his team is using AI to automate data entry and eliminate inefficiencies in clinical and hospital labs. Mark, welcome to the show.
Thanks, Lindsay. Appreciate you having me here.
Yeah, I'm thrilled. I'm thrilled that you're joining. Before we dive into today's topics, do you mind sharing a bit about your background and what led you to co-found PreciseMDX?
As you'd mentioned, I've been in enterprise healthcare for quite some time. Prior to that, I was in other industries like telco, financial, on the technology operation side. And I really enjoy the healthcare technology because it's complex. There's a lot of challenges in the market, and as a background as an engineer, I like solving problems, but also because I feel anything you do in healthcare that improves the process benefits people and affects them. So whether it's automating a process related to payments or scheduling more efficiently, you're having an impact on people's lives and health. So I really enjoy that aspect of healthcare. Throughout the years, we've done a lot of things, built practice management systems, rev cycle systems, clinical systems. And fast forward to about 5 years ago, one of my friends bought a large laboratory and called and said, the software here isn't doing what I needed to do. Can you come fix this? Which is a very broad statement. And we took a look at it and saw that, like in many industries, the labs had a lab information system that ran the clinical side, like the EMR part.
Yes.
The operational financial side was very lacking. There wasn't a clear solution in that area. And we kind of came in and started the company and developed solutions around that to help the operational financial sides of labs, which has an impact also on revenue side.
I think what you're saying is there's really no one better to talk to about revenue cycle management, technology, and all of the different pain points, regardless of the specific industry you're in revenue cycle management. Technology and systems play a major role in whether or not you're going to be successful and be able to scale.
Yeah, and like in any business, you can use Excel and paper and do things, and I've done that myself. But if you want to scale and be efficient, you need to use the latest, greatest technologies in the correct manner. Personally, I actually ran a national clinical company servicing thousands of physicians across the U.S., and I had to bill out claims. So I experienced rev cycle not just from the technology side, but also I needed to get my billing done, and that was a very eye-opening experience of the complexity of that field and how technology can really help you scale and get paid.
All of the painfully manual processes that did exist and still exist today. So, along those same lines, challenges in healthcare RCM, revenue cycle management is critical for healthcare providers, yet many face significant challenges. From your perspective, what are some common inefficiencies and pain points in RCM today with what you've seen?
So I would say the lowest common denominator or common problem is data. So as good as the data you get is, if you're getting bad data, you're not going to get paid. And it's an easy statement to say, but the data can come from many places, from the patients, from people who refer patients to you. If you're a lab, you don't actually see the patient, you're getting it from the provider. So, just getting the right data and the right patient information, right insurance is I see again and again a big challenge. And then there's what I would call the more modern challenges where payers are using AI to automate denials, automate reviews. So they're getting more efficient at not paying you,
Yes.
and you need to keep up with them to get paid.
I think I just read pretty recently some payers are even going to start charging for a provider sending in appeals. I think second level appeals and beyond. They will have to start paying to ask payers to take a look at their appeals.
Well, there are, and I'm not going to say we did this back in the day when I had my company, but there was a strategy that you would just overwhelm the payer with paperwork and phone calls to get them to leave you alone. And it
Yes.
worked, but it was very costly, and that's why it worked. I guess this is their way to combat that, where, instead of someone calling every day on the claims and just, because there's a certain cost to denying a claim, level 1, level 2, level 3, and it goes up and up because it's more involved. So yeah, that's probably a cost savings measure on their side. They tend to increase the number of pre-authorizations that they want, because that's another way to, instead of getting to a denial stage, just upfront, not having it happen. So they do have a lot of strategies. I actually worked also on the payer side on the quality control systems, which decide what claims get denied. And I'm not going to say too much about that, but they want to maintain quality, but they're also a financially driven organization. So there's a balance between the two.
Oh, they need to be profitable. We know that they are. Right. Another pain point, at least that I've come to know very well with many large any provider organization, but especially the large regulatory compliance issues and keeping up with the ever-changing regs that require constant vigilance and adaptability, which again plays into the systems that providers are using.
Yeah.
Can you use those systems more effectively and efficiently to stay on top of all of the different regulatory compliance issues? Have you seen anything that that you think will help providers in the future as it relates to these regulatory compliance issues and systems?
Yeah, 100%. Like if we take, for example, LCDs and NCDs that come out of CMS. So they come out at certain frequencies regionally. If you're a regional operator, you have to, look at the national and your local ones. If you're a national player, you have to look at a lot of them. You could use artificial intelligence to do, natural language processing on the documents and then query them and say, does this affect the business I do? In what way? Because today you have companies or people who that's their whole job. It's just
That's
going
right.
through regs, understanding them, looking for, the CPT codes we bill, and is the CPT code in there if you're, ambulatory. So definitely the latest technologies, the advancements in artificial intelligence can automate and make that more efficient. It never replaces 100% of the job. I always say AI will do 80% of the job. So it'll flag it, identify it, and then turn it over to a human to, make a decision, which is perfect. So that's one example. I think another one is also just, sometimes there's unpublished changes. So a payer will make a change to their system saying, I now decide that this number of units is not reasonable, and you just have to kind of be aware of it from a denial perspective.
Right.
So, and again, if you have the right systems in place, you could proactively be like, I've built this a certain way forever. I'm used to getting paid. All of a sudden, for this payer, this combination is giving me issues. Jump on it right away before, it piles up.
I think that's right on. In the way that you described using technology and AI, there are certainly benefits to helping keep providers up to date and proactive in tackling all of these things coming at them. Um, the healthcare industry is continually evolving. Where do you see providers struggle the most in adapting to these changes?
So, whether the providers bill for themselves or use external companies, which, by the way, I think makes a lot of sense. When I had my own company, we were quite large. We started billing ourselves, quickly realized we're not a billing company, that we need experts for it, that we're experts at other things. Tried on a few different companies till we found one that was a good fit. And so that's one thing. I think providers need to realize that, you can't do everything.
Yeah.
And revenue cycle companies have their place because they have the tools and the relationships to allow you to do your business, and it costs less. I'm not a rev cycle company, but just my personal experience and things I see in the market, it makes 100% sense to outsource unless you're really large and can really run an internal RCM operation. The challenges are always the usual ones. It's getting the right information. I think today, patients have higher deductibles, so you have to have good strategies around how to identify if the patient's going to be significantly out of pocket to warn them, but also to collect upfront
Yes.
and, get paid for what I'm doing. And just staying on top of stuff. Because if you get denials and you don't appeal them, and you're just like, oh, I don't have time, you get into the spiral of the payers will assume you're not doing things the right way, and it'll increase, and you get more denials. Because obviously, if they ask for records and you didn't send them in, then you're not doing things the right way, and they're gonna get on your case. So you really have to just be on top of everything. And I just see this again and again where people kind of, there's so much work, it's overwhelming. They just kind of push things off, and they don't get paid for their work, and it creates a real hardship for the practices.
And to the point that you were making, in outsourcing in general, whatever that may be, you're allowing another group of people to specialize in something so that you can specialize in what you do. So I couldn't agree more with that concept. And then, I think it's a great point on the kind of patient-centric technology. Helping patients understand, their medical bills up front is huge. Deductibles are only growing. A lot of patient out of pocket is only growing. And to surprise patients on the back end is never a good thing. It's never a good PR move for those organizations that have to bill those patients. That the patients claim they didn't understand what they were in for before those services were rendered. So having that upfront knowledge, I think, goes a long way in creating that trust between the patients and the providers. So technology plays a huge role in that.
Yeah, I mean, they recently came out with the No Surprises Act that is applicable to certain types of providers, where they
Exactly.
said patients need a good faith estimate so they're not surprised by their bill.
That's right.
And that makes sense. Like, like there's always the analogy, you go to a restaurant and after you're done eating, they tell you how much things cost. And, healthcare, the knowledge is there. Like, people have charge masters. They know how much things cost. They know your insurance. They know what you're going to go out of pocket with fairly high accuracy. There's the technologies in there to communicate it efficiently with the patient. One of the things we do in the lab space is we do that because the patient isn't in front of the lab. It's an interesting relationship where a provider sees the patient, orders labs, the labs get some information, runs the test, bills the patient. The patient and the lab have never really communicated. And the provider doesn't bill for the lab work. So the lab is the one billing, and the provider has no idea. My wife's a physician. And, I think a few months ago, a patient came to her office very upset that they got a bill from a lab that she had sent out. She's like, well, I'm not the lab. And they're like, well, you sent it to the lab. She's like, yeah, you needed it or else I'd have to amputate your foot because you had an infection. So you did this clinically. And they said, yeah, but you didn't tell me that this lab cost this much. Or I think they were even in network, right? They just had a high deductible plan. The patient's right. They're like, no one told me I went to the doctor, then I got this bill from this person I've never met.
Yep.
And I know there was a lab done. So yeah, technology can play a role in increasing making a better, I would call it, better experience for patients and providers.
Absolutely.
Yeah. So that's a great example of how it can improve it. It also improves the whole rev cycle process by letting people know what's going on and who's paying for what.
Patients do associate all of these things to their provider, even though the provider isn't the one probably doing much behind the scenes anyway. But they associate. So another quick question, Mark. We see a lot of posts and at all of the conferences, everyone's talking about technology, automation. I mean, they really are. They're all real, but they're buzzwords. They are buzzwords in healthcare today. How are these innovations truly impacting RCM? And we have talked about that a little bit here, but just wanted to get your take because you hear it everywhere. And I think everyone claims they have all of these things. But what do you think are really the innovations impacting RCM in these areas?
So, we do quite a lot. I work with a lot of these rev cycle companies. I just came back from HIMSS. There's a lot of AI. I was joking. I was like, who's this Al guy? Al. But it's AI everywhere. Most of it is marketing, I sadly say. Some of it's automation, which is good, but it's not using true AI or true AI capabilities. Things that I've seen in AI that work well. So using because AI has been around for a long time, but now the tools are more accessible and more mature. Some things I've seen work well in RevCycle is things like correspondence management. So there's still a lot of paper that comes to RevCycle. Yeah. You get denial letters, you get paper UBs, you get spam, you get notifications. One RevCycle company I was working with, they would get thousands of pieces of paper a day in the mail. And someone would open the mail, read it, put it in a pile, scan it. So now they use AI to do correspondence categorization. Is this a denial? Is this spam? Is this something to do with compliance? And that alone saved them, 30 FTs a month.
Wow.
From just opening the mail, scanning, reading, understanding, and the error rates are reduced. So that's a great example of real AI used to impact revenue cycle in a way that people didn't realize is important. And there's other examples too, like with denial predictors. So you can use machine learning to track it. A lot of people use just algorithms and automation, which is fine, right? Because you're still using technology. But if you have enough of a data set, you can use the machine learning part to understand things beyond what I'd call intuitive low-hanging fruit. Like, I know that I've been in rev cycle for 10 years and I'm billing in this space, and I know that these things happen, so I'm going to build in these rules, right? That's what's been going on for a long time.
Yeah.
AI part is like spotting stuff you didn't think of. So there's definitely applications of it. I haven't seen a company out there and there might be one doing it well at large scale. I see a lot of companies building it internally themselves. And there's not a lot of rev cycle systems out there in general. It's not like companies that have, I sell an RCM solution. A lot of people just have homegrowns and things like that. So
everyone's trying to figure it out. You've been at the forefront of designing systems to improve RCM performance. What do you think in today's standards are maybe the top 3 things that a good system should have? Like at minimum, it should have.
that's an interesting, that's a hard question. So I'll say, I don't know if I can think of 3. I'll tell you things that I've built and I've seen be effective and are still applicable today.
Awesome.
One is you need an end-to-end view of the claims and the encounters. You need to know how many are coming in, how many went out, how many got paid, and in a very simplistic way, just to make sure there's no leak in your rev cycle pipeline, I would call it.
Yeah.
And people don't realize the value of that. They kind of have like all these really complex days in AR dashboards and DSOs and like this and slicing and dicing. And I always say, you need one simple one just to make sure there's no leaks. And once they put that in, they find leaks because things happen. Another thing I always tell, whether it's internal or external teams, is you want to know how many times people touch things. So you can get a sense of how hard it is working on certain items or certain payers, and also use it to educate your staff. So I always say to them, just implement a simple system. How many times did we touch this claim until it got paid? And then that's where you can measure things. So it goes about low level kind of measurement of data, so you can improve your processes. So those are 2 things that, over the years, when I had my own company or when other systems, we always build it in. It's always effective. Even today, I talk to some rev cycle companies. That's a big one. And then just, every rev cycle company has different SOPs internally, standard operating procedures. And I would say, look at areas where you're doing things that are repetitive, that, moving data from one place to another, just looking at something and clicking on it. There's always these repetitive things they're throwing people in Excel at, and just go after the low-hanging fruit and start to automate those areas. You'd be surprised at the efficiencies and the error reductions you would get. That's kind of a general one, but I see that again and again.
I agree with everything you just said. It's funny when you say it like that, it also seems pretty basic, but it's not. You would think it should be, but it's not. For those of us that have worked in a lot of different systems, it's not.
Yeah, and it sounds easy when I talk about it because, it's like, oh, just do this and that. But
right.
I'm working with a rev cycle group. They're several thousand employees. They're friends of mine. They actually used to do billing for me back in the day for my companies. That's how I know them. And, I talk to them about AI because, I read a lot, and I talk to Chad, it tells me things. And I say to them, how do you have so many people? And they're like, well, we do this and that. It's like, I have a sense that, I'm not saying, fire people. I'm saying you can scale with your same team to get more customers if you apply automation. And, the benefit is that you do things more efficiently. It's more cost effective. You can pass that cost on to your customers and be more competitive and do a better job, right? And everybody benefits. You benefit,
that's right.
The patients benefit by not, I'll give you an opposite example. I was recently talking to a large lab, and their billing team, had an issue with something basic of just checking eligibility of the insurance. And I said, well, what do you do if the claim gets denied? You say, we drop a bill to the patient. I was like, what? I was like, you don't try and figure it out. They're like, no. And I was like, and I went online, and their Google reviews have all complaints from patients saying, I got a bill and I have insurance and I sent it to them. And I was like, and they're not doing well. And they have Better Business Bureau complaints, and it's a technology process thing that is not that hard to solve. But
No, it's interesting. I've been as a patient, I've been on the other side of that, where you have insurance, you think all the things up front that you're supposed to, and you get a bill because your insurance denied it for XYZ reason. And that is the process. It is written in the SOP. Bill the patient. Let the patient figure it out, because it's easier that way. We don't have to staff for it or solve the problem. Let the patient figure it out. If they don't want to pay it, they'll call their payer and fix it themselves. It's a turnoff to patients. I don't think I ever want to go back to that particular place again, even though I like the doctor a lot.
we're in healthcare, but I get questions all the times from family members or friends not in healthcare about, well, I got this bill, and I look at it as like, oh, they balance bill you, they're out of network. Go back and say, not cool, or you didn't sign an ABN, so
That's right.
Or even I
That's
had
right.
someone in my company call a hospital. They had this lab work done, and they had some extra labs that were not the regular ones. They got a big bill, and I said, pull out the No Surprises Act, and they called the billing department and said, I didn't get a good faith estimate, and they're like, hold on. It's like, okay, we waived it. Like they were like, okay,
Yeah.
I'm not saying people should do that, but I'm also not saying people should just balance bill patients just as a mechanism to see who will pay versus who will complain. That's also not a good way to do it.
Market it's all very complicated. And for the average patient or the average person coming into this industry, it is complicated, which is why technology and expertise really do play a big role in all the things that we're talking about. My next question is kind of maybe very similar to one of the first questions I asked you, but flipped. So from a technology standpoint, what are the biggest pain points in RCM? We talked about from the provider perspective in RCM, but from a technology standpoint, what do you think some of the biggest pain points are?
Interoperability. So getting the information from the provider system and also communicating it back. That's
Yes.
always a challenge for many reasons. It's a technology challenge. It's a project challenge, like getting the EMR hospital system vendor or hospital IT to connect with you and get
Yes.
data and understanding how they map the data and how you map it. And some companies work inside their system and some are outside. So data, getting the data, whether it's accurate or not, is a challenge,
Yes.
I think. And then again, just the fact that there are no revenue cycle systems on the market for sale. Like you can't go and say, I want to buy an RCM system. You have to, a lot of companies I work with use practice management systems to do their revenue cycle work, but then they augment them with Excel or internal systems. So, I don't know if there's a space in the market for a revenue cycle system vendor, but I see a lot of point solutions. I like experts at
Yes.
eligibility and insurance, experts at pre-auth, a lot of dashboard companies that'll take your data and crunch it and give you analytics on it. But I see that as a problem, the interoperability, and then the just the systems they use is a challenge. And there are a lot of revenue cycle companies out there, a lot, from moms and pops to the big ones.
Yeah, no, and I mean, I think probably regardless of size, to some degree, they're probably all being faced with the challenges you just mentioned, data
Yeah.
fragmentation and getting what you need to do your job. The future of technology in RCM. Looking ahead, how do you envision technology evolving to address systemic challenges in RCM? Some of the things we've already talked about. How do you see it evolving?
Well, I definitely the AI aspect is gonna take a very dominant place because payers are using AI to deny, and to keep up with that, RCM companies and groups are gonna have to use AI to appeal, because otherwise you're just gonna drown, and you're gonna have AI bots talking to each other on the phone, which is
Yeah.
gonna be hilarious. Because payers use AI now when you call,
Yes.
and RCM companies use AI too to call payers.
Yep. Yep.
And I'm sure if you're a human talking to an AI, it's frustrating. But I don't know if you can just hang up the phone. I don't know if that's allowed or not. I'm not sure what the rules are. Like, I'm pretty sure payers are going to install systems that detect that it's an AI and route them to a voicemail, or like there's going to be all these like stopgap measures to
Yep.
figure it out. But you're gonna, to keep up. with what the payers are doing, you're going to need to use more AI, and also
Yeah.
to be competitive. Like if you're going to see these new RCM companies that have very small staff that are highly automated using different aspects of artificial intelligence, and they can charge less because the FTEs are the main cost, and you're going to have to keep up with them. Yeah, you're going to you gotta technology is moving very quickly these days, and people need to capitalize on it.
I think those are excellent points. And the answer is yes, they definitely can detect when you have AI calling in, and they figure out how to reroute you, so you can't accomplish what you set out to do with that bot. What advice would you give to providers hesitant about adopting new technologies?
So I would say, first of all, there's experts out there. Talk to an expert. Like, don't read up some stuff on the internet or hear what your cousin's doing. There are people that's their expertise. They're not necessarily rev cycle companies. There's people who do consulting who could just come and tell you, am I doing a good job? Could I do better? Should
Yeah.
I keep it in-house? Should I outsource it? I mean, I think there's a company out there, Claims Theory, that does that, but there,
Oh
there,
yeah, I've
there,
heard
there's
of them.
there's some other people, and like you have a lot of experience in revenue cycle. You could probably come into any industry and just tell them you're doing a good job or not. You could just smell it when you walk in, and then you could dig in and figure out why. And I've seen provider practices where I was like, you're doing a great job. Don't outsource your billing. And I've ones like, I have so many from my history anecdotes. Like I worked with a large cardiology group on the East Coast many years ago. They're a customer of mine, and I wasn't advising them or consulting with them, but they said, "Oh, we have this imaging center, but we get paid on half of the stuff we send there, but it's still profitable." And I was like, "What?" I was like, "Why?" They're like, "We don't know." I was like, "How about this? I will keep half of what I find from that half you don't get paid on." They're like, "No." I was like, "Well, how about I just give you some help?" And they just weren't checking insurances, and they were missing some contracts, and it was a significant dollar amount, but they were profitable, and the imaging center was an ancillary, and they were like,
Yeah.
whatever.
Yep.
And if they just spoken with someone who understood anything about rev cycle, and they had like an internal team, and their head of RCM used to be like their office manager who kind of grew into the role, who's very capable, but only knew what they knew.
Hmm.
So yeah, 100%, talk to an expert
Yep.
and then make a plan, right?
Yeah.
I say that for everything, right? But
Yeah.
definitely rev cycle, like it's very complicated.
It's very complicated, but that's great advice. I think, and I'm not saying all providers fit in this box, but they're afraid of change. They might be very comfortable with a particular system
Mhm.
that they're using, and even though they know this new one that seems to have all the bells and whistles might answer 80% of their pain points, they still might not choose to go forward with it for the sake of not wanting to change and disrupt what they're doing. So it's just interesting.
Yeah, change management is interesting. My wife's practice is switching EMR PMs now and hating it,
Yeah.
and I was like, "This will be good for you, believe
Yeah.
me. I know what I'm talking about." And she is hating it.
Yeah.
And it's like, you're just not used to it, but you'll see this will save you time.
That's right.
You'll make more money. Your
That's right.
patient will be happier, suffer for a few weeks of change. And I think if I wasn't there, and I didn't sell them an EMR, I don't sell EMRs and PMs, but if I wasn't there, it wouldn't happen. They would have like been like, nope, we're not doing it. And it's definitely, they're using some ancient technology. I don't want to name names, so
Yeah.
everybody
Yeah.
that they're using like a bad PM and a really old EMR, and they're moving to a pretty good one. And yeah, I know it'll be good for them. They don't want the change, and it's like that everywhere. But
Yes.
when you get stacks of paper EOBs because your PM can't take ERAs, that's a sign, right?
Right. That's but I think again just validates the point. Change is overwhelming. And to your very valid point, talk to experts. At least explore what those options look like before just outright deciding that it's just not something that you want to take on right now, because the benefits probably
Yeah,
far outweigh going through the training and all of the motions and everything that goes into changing something. The benefits probably are worth it.
yeah. I've never seen any provider operation that get paid on 100% of what they do, ever, never. And then the percent they don't get paid on varies from 5% to 30%. So
It's
so
scary.
and sometimes they know and sometimes they don't, right?
It's a really scary figure. Probably more often than not, they don't know. They don't know what they're not getting paid. Mark, it has been enlightening to discuss the challenges and technological advancements in RCM. Your insights into integrating technology to streamline process and improve patient outcomes is invaluable. And you really are a wealth of knowledge, and not just in revenue cycle management, but technology. So for our listeners that are interested in getting a hold of you to talk more about this, and perhaps help them, how can they get a hold of you? What's the best way?
Well, you can find me on LinkedIn. That's always good because I think LinkedIn works. Email mark at precisemdx.com is good too. And, I'm always happy to chat. Doesn't matter what my role is today. I'm a product person at heart. So I like, solving things in healthcare and looking at healthcare products. So I'm always happy to chat with anybody about anything in healthcare. I tend to be optimistic, maybe naively so, that things can get better and be fixed. And I've seen it happen. So yeah, like I said, happy to chat about anything. Done a few things in healthcare. Happy to share my experiences. I have opinions and knowledge, but yeah, everybody decide what they do with it.
Mark, and to our listeners, thank you for tuning in to the Claims Theory podcast. And if you have any questions or topics you'd like us to explore in the future, feel free to reach out. And thanks for listening or watching, however you choose to digest your podcast. Appreciate all of you. Thank you so much.